Oh, okay. Shall we start? Jenny ma'am, are you ready?
Sir, yes, sir.
Okay, okay. So, good morning, everyone. So, I would like to welcome all participants to the webinar, which is organized by IPEL. So, IPEL is nothing but Interactive Physio e-learning. So, it is a learning platform where we used to conduct a webinar from now on weekly. So, today I would like to welcome Dr. Professor Santosh Raja sir, MD, to the online webinar. Sir, welcome, Santosh Raja, sir. And next, I would like to welcome our today's speaker, Dr.Janani ma'am. She is going to take a webinar on pathological gaits. So I would like to welcome Dr. Janani ma'am. And she is an associate professor from Nandha College of Physiotherapy. Welcome, ma'am.
Thank you, sir.
And myself, Fernandez Franklin, Chief Administrative Officer, IPEL. I'm M.P.T Neuro. Thank you. And I'm handing over the mic to Janani ma'am for the webinar session. Ma'am, kindly share your screen, ma'am, please.
Yes, sir, sure, sir.
You can start, ma'am. So so participants, kindly mute your microphone. You can have your ask your doubts in question answer session at the end of your webinar. Thank you. Thank you, everybody. Janani ma'am, you can handle. You can start.
Yes, sir, sure, sir. So my screen is visible, sir.
No, ma'am. Till now, I am not able to see your screen. Can you please share? Now it is visible, ma'am.
Yes, sir.
So, participants, if you have any technical difficulty, means kindly text here. Okay. Thank you. Thank you, ma'am. Kindly start, ma'am.
Yes, sir. First of all, good morning to everyone present here. Myself, Janani, Associate Professor from Nandha College of Physiotherapy. Actually, I should thank for this opportunity to Santosh Raja sir and the Franklin sir from IPL. Thank you so much, sir, for giving this opportunity. Let me start with the session. Today, I am going to present a topic on basics of normal and abnormal gait. Hope my screen is visible. Students, please, anyone?
Yes, ma'am. Visible, ma'am. Kindly proceed.
Yes, sir. Thank you. So, in I have started with my session with my traditional, that one is to praying a God, that is Almighty. Prayer requires more of the heart than of the tongue. So I thank God also to give this opportunity. It is a quote I liked so much. It is, don't walk behind me, I may not lead. Don't walk ahead of me, I may not follow. Walk next to me and be my friend. So said by Albert Camus. So we go into the topic, that is a gait. Gait is nothing but our locomotion. It is one of the important thing in our life, in also in our ADL activities. Without the locomotion, we cannot survive. We cannot live into the fulfilled life. So with the locomotion, we can transfer from one place to another, and also we should not have any kind of discomfort. If any kind of discomfort occur, it also leads to an improper gait. A method of locomotion involving the use of two legs, the alternatively to provide both support and the propulsion will occur through the gait. It is a type of locomotion in which our body is transferred from one place to another place. So, in order to the locomotion, we have to accomplish the four things. The first one is the support of our body weight through the leg without any collapsing, and the balance, it should be maintained statistically and dynamically during the single leg stance. That is, if we walk, we have to balance both the stance phase and also the swing phase. If without the balance, we cannot transfer the whole weight to the one single limb. So that's why here balance must be both statistically and dynamically we have to manage. And the swinging leg must be able to advance to a position where it can take over the supporting role. That means a single swinging leg will have the most toughest job, because it have to hold our weight without the ground support. That is why the swinging leg will have the most uh, discomfort job, and the sufficient power must be provided to make the necessary limb movements and to advance the trunk. It means the muscle power is also most important one while we are doing the locomotion. So without the muscle power, especially anti-gravity muscles will work most prominent over here. So without that anti-gravity muscles, we cannot able to stand, and also we cannot able to hold, we cannot able to wait through the limbs. In normal walking, that is, each of these requirements with the achieved without any difficulty. If any there are many pathological conditions like we are seeing in our day-to-day life, as in our relatives also, and also in clinical side. If you have any exposure over the hospital side, you can view this kind of patients like with the use of walker, crutches, cane, or any orthopedic device. Both in a surgical part, they also have to use this, and also if any other neurological conditions like stroke or Parkinsonism, like that, they also have to be dependent. That means they cannot walk without support. That means they lose their muscle power and also lose their locomotion because of that loss of a muscle power or the whole limb activities. So, to failure to achieve all four requirements, the subject is unable to walk. They will be completely on the dependent side. So, the complex interaction between many neuromuscular and the structural elements of the locomotion system. So, abnormal gait may result from a disorder in any part of the system. So, especially in the neurological or in any structural elements, it means that any ortho conditions also. It may also result from the presence of pain. So some may have difficulty in walking due to the pain also. It means exaggerated pain, especially the example is sciatica, or the complete limb will get radiating pain. They may get difficulty in the walking. So the gait cycle definition. So normal gait in the sense it is a series of rhythmical and the alternating movements of trunk and limbs which results in the forward progression of the center of gravity. Here the center of gravity is placing a crucial role here because without the center of gravity we cannot stand against the gravity. That is, alternating movements of trunk and limb should be rhythmical and also the series of movements should occur. So, without this, we cannot have the smooth gait. So, and also it is otherwise called as a series of controlled falls. Why it is mentioned as a controlled fall in the sense if we have unbalanced or as we have seen in the previous slide, if we lost the balance and we have lost the muscle power, we cannot able to withstand, that is we can may get into a fall. It may result in the fall. And also here the cog will plays a main role. The cog also will shift to the affected side, so it may there may be a chance to get a fall. So the series of controlled fall is equal to a normal gait. The next is a gait cycle. Here, the gait cycle is nothing but a single sequence of functions by one limb. That is, in the picture, you can able to see the gait cycle, complete a gait cycle. The first thing is started with the right limb. The right foot is placed on the one side, and the same right foot will have the end in the another part. It results in, it is called the gait cycle. That means one complete sequence of this limb. So the right, left, and then right. The complete sequence is nothing but the gait cycle. In this, in between this right limb, right, that is a right heel contact to the right heel contact again, this have the major part, and in between this have the mini sequence. With this begin with when reference foot contacts the ground and end with the subsequent flow contact with the same foot is called the gait cycle. The next is a step length. It is nothing but the right heel contact with the ground. The next is left heel contact with the ground. The difference between this two part is called the step length. That is the distance between the corresponding successive points of heel contact of the opposite feet. The right step length and the left step length, that is in normal gait, it should be equal. We have to measure from the right heel contact to the left heel contact, and the same with the left heel contact to the right heel contact. That is a right step length and the left step length, it should be equal. So this is called the step length. If it is equal, then we have the, we can decide it is a normal gait. The next is a stride length. The stride length is nothing but the distance between the successive points of heel contact of the same foot. That means here, as I have said already, the gait cycle, complete gait cycle, that is the heel contact of the right foot and again the heel contact of the right foot. So the distance between these two is called the stride length. So that means nothing but the double the step length. So it is also called as a double the step length is also called a stride length. So the next is walking base. Walking base is nothing but, so imagine we have placed both the feet in one side. That is before we start our walking. So the side to side distance between the line of 2 feet is called as walking base. It is also known as stride width. Here we have marked this walking base. That is a base of support. We also called as a base of support. So if we have reduced the base of support, then we can have an easy chance of fall if any neurological conditions. You may also known as the Trombeck test. That is, we can ask the patient to stand with the feet apart, closed feet apart, and both the feet together with eyes closure and the eyes open. This is called the Rombeck test. So to measure, the main thing to measure about the walk base of support only, we can check with that Rombeck test. The next is gait cycle definition, that is cadence. So cadence nothing but the number of steps per unit time. It means we can walk many steps per unit time. That means if in a minutes we can cross around 30 steps or 40 steps. It may differ from the person to person. The normal cadence is 100 to 150 steps per minute. So we can walk with the 100 to 115 steps. And also they have a difference in this cultural and the social variations, because in some patient, some person, there may be a habit of a slow walking. Some person will have the habit of fast walking. And here, and also we can share that the female will have a more cadence compared to the male, because the female will also have, that is a short limb, that the step length will be lesser in the female compared to the male. So that's why here this, because of the step length reduction, there may be a chance of increase in the cadence level in female than to the male. So it may cross, in female it may cross around 140, and for male it is around 120. The next is velocity. So the velocity is nothing but distance covered by body in unit time, as same as in cadence. Here we measure the distance level. So usually we measured with m by s, that is meter by second. Instantaneous velocity varies during the gait cycle. So the average velocity is meter per minute. The step length measurement, we have to measure the step length level, and we have to mention in the meter and into cadence level. So the example of velocity is example for step length in both the right and left we have to measure. If it is around 10 meter to 20 meter into, we have to measure with the cadence level per minute for the particular person. So if it is around 100, so we have to equalize it with step length. That is, example, the step length is 20 into 100 is around if anyone can share, that is 20 into 100. Anyone can tell the students what is the average velocity if we have the step length of 20 meter and the cadence of 100? Students, it's okay. We carry on. The average velocity will be around 2000 per minute. So the next is comfortable walking speed. It means everyone will have the comfortable walking because of our energy. So here the energy will play a major role. It means the least energy consumption per unit distance. That is, if we spend our energy less, So our distance covered will be 80 meter per minute. Okay. So here it will be around 3 kilometer per hour, sorry, 5 kilometer per hour or 3 meter per hour. 3 kilometer per hour. It is approximate value, that is because of the comfortable walking speed. So if we walk slow, we will have the 80 meter per minute of the energy consumption. So especially while we walk slow, if we have a speed walking, it may increase up to 8 kilometer per hour also, and also 10 kilometers per hour. So it like we have, you can see the film also, somebody will have some of the heroes will have a different walking style, like Rajnikant will have a different unique walking style, and the Kamal Hassan will have the different walking style, and Vijay will have the different walking style, like that. So it depends on the every individual, the unique walking pattern will be differ. And also uh, and also here I would like to share the example, like in marathon, many people will have, we can easily see many person, we can conclude that 8 kilometer or 10 kilometers within an hour, or a 20 to 25 minutes they can complete the session without the muscle power and without any workouts. That person cannot complete that easy target. So that means 8 kilometer per hour is very very toughest, that also they can achieve through this muscle power only. The next is a components of gait, that is a phases. It is a important question. Here there are two phases of gait is there, that is a stance phase and the swing phase. The stance phase is nothing but the limb will be in contact with the floor. The swing phase is nothing but the limb is not in contact with the floor. It will be in the swinging position, and it will be in contact with the stand space is nothing but in contact with the ground. The support is also is divided into two types, that is a single support and the double support. The single support is only one foot in contact with the floor, and the double support is nothing but both feet in contact with the floor. So there may be a increase in single support only during our gait cycle, and the double support will be lesser period. In stance phase, there are five more types. That is, the first one, heel contact. You can see in the picture, the first one, the heel contact of the right limb is occurred. So here the person is making the heel contact of the right limb, and the next is foot flat, the complete loading of our body weight to the right limb is occurring, that is the second one. And the third one is mid stance. He going to complete his stance phase, that is a mid of the level of the stance, that is complete body weight is happening on the right limb alone. And the fourth one is heel off. It is going to be end of this stance phase, that is if the heel off occur, that is it is called the terminal stance. And the last one is toe off. The toe off nothing but pre swing phase. The next phase is a swing phase. So before that, it is initiation of the swinging phase is nothing but the toe off. So here the heel contact is the initial contact of the stance phase. The second one, foot flat, that is nothing but the loading response, initial contact of the forefoot with the ground, that is called the foot flat. It might be complete. Our body weight is going to take a response to give on that particular limb. The third one is mid stance. Here, the greater trochanter in alignment with the vertical bisector of foot, and the heel off is the terminal stance, and the last one, toe off, is the pre swing. The next one is a swing phase. Here, the swing phase is having the three types, that is acceleration, mid swing, and the deceleration. Acceleration is nothing but the initial phase of the swing phase, and the here acceleration is nothing but the complete foot is off ground. Okay, that is the right limb is completely off the ground. It is not in contact with the foot at all, and is also behind our body. That is, the complete trunk is forwarded and the our foot is in behind. So that's why we are it is called as a acceleration. The next is mid swing. Mid swing is nothing but the foot is again going to be the stance phase, that is a mid swing. Swinging limb overtakes the limb in stance. So here the left limb is taking part in the stance phase. So it is overtaking this stance phase is called the mid swing. The last one is deceleration, nothing but it is the terminal phase of the swing phase. That is, it's going to be a end part of the swing phase. That is, again the heel contact going to occur. So it is called the deceleration. So it is a complete gait cycle. You might know this picture, I think so. Students, you are being in a first year or a second year. Can anyone answer? Can anyone? Students from which year are you here? Anyone?
Final year.
Sorry? Sorry, I couldn't hear.
Second year.
Final year. Final
Yeah.
year.
Yeah, okay, thank you. Okay, you might have looked into this picture, I think so. So here there are, it's mentioned as both the right and left heel. That is a double support. The initial will have the double support. The first thing is a right heel contact, then the left toe get off. That is, if one limb is in the stance phase, the another limb will be in the swing phase. Okay, so in between we have the double support. The double support timing will be very less. The next again it starts with the right will be in swing phase and the left limb will be in the stance phase. So you might understand this picture, I think so. So it is complete gait cycle.
Ma'am, can you tell again?
Yeah, I will tell. Here you can see this left limb and the right limb, right? So in this left hand side, that is a left limb and the right limb. Initially, we have placed the both limbs. Okay, we before we start our gait. So initial we start with the right heel contact. That is, we start with the right heel contact here, and the left toe is getting off. Okay, because and the right limb will be in the stance phase and the left limb will be in the swing phase. Okay, it will be in completely swing phase, and right limb will be completely in the stance phase. So the first thing, as I said before, the stance phase completely will occur only in the right limb, and the left limb only will have the swing phase. The next, again, it's getting a vice versa. While the left heel contact occur, it starts with the left limb will get the stance phase and the right limb will have the swing phase. Okay, you got it?
Got it, ma'am. Thank you.
Yeah, yeah, it's okay. The next is time frame compared to the stance versus swing phase. In the stance phase, we have the 60% of gait cycle, and the swing phase will have only 40%. As I said, as we saw before, the stance phase having the five classifications and the swing phase having the only three classifications. And also, while contacting with the floor, that is, our ground contact is more in the stance phase and the swing phase part is less. That's why we can able to balance throughout our gait cycle. The next is single versus double support. So single support is nothing but only one limb will be in contact with the ground. Here it is a 40% of gait cycle will be in the single support. That means most of the part in the swinging phase. And the double support is very less, that is only 20%. That is both limb will be in the ground. It is while at the end of the session only we have contact the both heel with the ground. That is the double support is only 20%. So while increasing with the walking speed, the stance phase will get decrease and the swing phase will get increase and the double support will get decrease. So because why? Because the stance phase is nothing but we have contact with the ground. That is, if we contact more time with the ground, then our walking speed will be less. But if we walk slow, the stance phase will be more and the swing phase will be less. So it is vice versa. That is example in running we have only less time of contact with the ground. Our leg will be less time contact with the ground. Here the ratio, that is stance and swing, reverses. The double support disappears, the double swing develops. Nothing but the double support, if we have a double support decrease only, we can able to increase the swing phase time. Okay. The next is path of center of gravity. It is a main hero of this gait. Nothing but the center of, without the center of gravity, we cannot able to stand, we cannot able to walk. Can anyone say where is our center of gravity located in our body? Can anyone say where?
Anterior part of sacrum.
Sorry?
Anterior part of sacrum, S2.
Yeah, good. Very good. May I know your name, please?
Prarthana.
Prarthana is very good. So, as she said, it is exactly over the second sacrum and also in front of the sacrum. Okay, few centimeter in front of the second sacrum is our center of gravity location. It is the midway between the two hips. The least energy consumption if the center of, sorry sir, sorry sir. Prarthana, please.
Ma'am, from Bethel College of Physiotherapy.
Sir, Negru College. Okay, dear, thank you. Okay, so here the least energy consumption if the center of gravity travels in the straight line. That means if the center of gravity is not traveling in the straight line, there will be more energy consumption will occur. We'll have deep into it. So in this picture, as the center of gravity in the second sacrum location, and while we have a forward bend, it is forward. This is falling directly over the straight line. If it is not for not a the center of gravity is not. Yes, sir. So if it is not falling in the straight line, then it will be is difficult to withstand with the forward bend position, because if the center of gravity is falling to the right side, then we easily fall into that side. So the center of gravity should follow in the straight line. So it is also can demolish with the loss of our balance. The next is vertical displacement. That is, if our center of gravity is moving up and down, that is a rhythmical movement of up and down movement during the mid stance level, it is moving the up and down movement, that is a vertical displacement of our center of gravity. The lowest point in the double support, that is a vertical displacement of COG is lowest in the double support region. The average displacement is occurring will be 5 centimeter. The path is nothing but extremely smooth sinusoidal curve. So you can look into this picture. The man is standing near to the car. Again, he walked towards here. Okay, so he walked some distance. He covered some distance. In this, you can saw the sinusoidal curve. Okay, it is nothing but a center of gravity. Okay, so the center of gravity is smoothly moving the small up and down movements. This is nothing but a smooth sinusoidal curve. Okay, so this is why we can able to complete the smooth gait also. Without this smooth sinusoidal curve, we cannot able to complete this gait pattern, that is normal gait cycle. The next one is lateral displacement. It is nothing but rhythmic side to side movement, that is lateral limit is occurred in the mid-stance level. It is also the average displacement of 5 centimeter, and it is also have the extremely smooth sinusoidal curve. The next is overall displacement. So both vertical and the horizontal displacement, that is sum of the vertical and horizontal displacement. Here we can look into this picture, that is a horizontal plane, and here down is a vertical plane. A is mentioned as horizontal plane and B is a vertical plane. So the figure of 8 movement, center of gravity as seen from the anterior posterior view. So you can look at here, the C is a figure of 8. Here, how we calculate is the nothing but center of gravity order locations. The next is determinants of gait. So the determinants of gait, it is also important question, and also will be a repeated question also. So there are 6 optimizations used to minimize excursion of center of gravity in both the vertical and the horizontal planes. As we saw in before slides, that is the center of gravity will have both vertical displacement and the horizontal displacement. If it is not occurred, we cannot able to walk smoothly. So if we have a reduced significant energy consumption of ambulation, and this is mentioned in the classic paper, that is a Sanders Inman in 1953. So the first determinant of gait is a pelvic rotation. So the pelvic rotation is nothing but the forward rotation of the pelvis in the horizontal plane, approximately 8 degree on the swing face side. So during our swing phase, the forward rotation of the pelvis is occurring in the horizontal plane, that is only minimal, that is 8 degree. So why it is to reduce the angle of hip flexion and the extension. If more hip flexion and extension occurs, we can easily get the fall. So that's why, to reduce the angle of hip flexion and the extension, the pelvic rotation will occur during the swing phase. So it enables a slightly longer step length with a further lowering of the center of gravity. So here in this picture, you can see this pelvic rotation. Only the minimal pelvic rotation is occurring while we get into, that is a forward, trying the limb to make the forward movement. So that time only the pelvic rotation is occurring. The next is pelvic tilt. Here, the 5 degree depression of swinging side only, that is in the hip adduction position. Okay. In standing, this depression is a positive Trendelenburg sign. So if that is, you can imagine the patient is having the pelvic drop on one side, that is called the Trendelenburg sign. So we see in this later slides. So in standing, if it is occur, it is called the positive Trendelenburg sign. That is the result of weakness in the gluteus medius. So reduce the height of effects of the curve of center of gravity. Here the pelvic tilt, you can see this picture in the stance phase and the swinging leg. Here the hip height is normal and the CG of height is reducing in the swinging phase. That is a 5 degree depression is occurring in the swinging phase. The next is knee flexion with the stance phase. So the knee flexion is also most important. Without the knee flexion, we cannot get the smooth gait pattern. So approximately 20 degree, that is a 20 degree of knee flexion should occur. So shortens the leg in the middle of the stance phase. So during the mid stance phase, this knee flexion should occur. So to reduce the height of the apex of the curve. Imagine if we not have the knee flexion during the stance phase, then what will occur? Anyone? If the knee flexion and stance phase is not occur, what will happen? We can able to have a smooth gait. Anyone? Students, anyone?
It will be difficult in getting the next step, or we might fall.
Yeah, good. So again, it's Pradhana.
Yes, ma'am.
Good. Yeah, okay. Thank you, dear. So here, as she said, we can, if we have, without the knee flexion, we can have a fall also. And then without the knee flexion, we have to hike our hip. Okay, the same side of the limb, we have to hike. Imagine the patient with the stroke. Okay, he cannot able to flex the knee, or the patient with the THR, that is a total hip replacement or the total knee replacement. In the affected limb side, they cannot able to flex the knee in the post operative day, that is a day 1 or day 2, they cannot able to flex their limbs. Okay, so in that kind of patient, what they will do, in the sense, they use a walker to walk, and also they will hike their hip. Instead of the knee flexion, they will hike their hip. It results in the Trendelenburg sign. Okay, so what I have to say this. So the next is ankle mechanism. The ankle mechanism is the most important one in our gait. So it lengthens the leg at heel contact and smoothen the curve of center of gravity. As we saw earlier, is sinusoidal curve. So to smoothen that sinusoidal curve, the ankle mechanism is more important. So, and also to reduce the lowering of center of gravity. That is, if the center of gravity is falling more down, then our heel contact will not occur as early. Okay, then the swing phase will be more on that. Then we can also have the fall of chance of fall. The next is foot mechanism. Here, lengthens the leg at toe off as ankle moves from dorsiflexion to the plantar flexion. You can see in this picture, the first thing is heel contact, while the heel off, the next is toe off. So in between this, we have we have to lengthen the leg. That is, we have to move forward propulsion. We should have the forward propulsion. If we not do the forward propulsion, that is, our trunk is not going forward, means we lost this foot mechanism. That time also we can get the chance of fall. So without the toe off, we cannot move our body to the forward. And here also the smoothen the curve of center of gravity, and also to reduce the lowering of center of gravity, this foot mechanism should occur. The next is lateral displacement of the body. That is nothing but, while we are walking, the lateral displacement of the body is also most important. That is, with the base of support. Okay, so normally narrow width of walking base minimize the lateral displacement of center of gravity. That is, if we have more base of support also, it may results in fall of chance. If we have less walking base also, there may be a chance of fall. So both should be, we have should be a normal base of support. The reduced muscular energy consumption due to reduced lateral acceleration and the deceleration. If we try to walk with more base of support, then the lateral acceleration and deceleration will get high. That is, our muscular energy consumption will be more. So due to the muscular energy consumption more, it results in the either the chance of fall, or we cannot able to continue to the longer distance. So it reduce the walking distance also, and also it reduce the gravity level. The next is cause of gait abnormality. Here we come into the pathological type, that is, movement being forced by the weakness, spasticity, or the deformity, and the movement is compensation, that is, which the subject is using to correct for some other problem. So here, weakness, spasticity, or deformity will occur if the patient get any kind of a neuromuscular disorder, as we saw earlier, any neuro kind of disorder or the orthopedic conditions. The patients will get the weakness, spasticity, or a deformity. Then the next one is compensation. As of like I said earlier, that is example. If the patient is having a pain, like a sciatica, what they will do means, to compensate that pain, that is to load that particular leg, they will compensate with the other leg, that is unaffected leg. So they completely load their weight to the other leg, and the muscle which we use for that affected side will be compensated to the unaffected side. So this also will result in the gait abnormality. The specific gait abnormality, the first one is lateral trunk bending. It is most important, and also it is most noticed one also. The bending of trunk toward supporting limb during the stance phase, nothing but Trendelenburg gait. So during the double support phase, the trunk is usually upright, but as soon as the swing leg leaves the ground, the trunk leans across towards the side of the stance phase leg, returning to the upright attitude again at the beginning of the next double support phase. So it means, you can look into this picture. So here we have this, we can notice this negative sign side. Okay, so here the muscle also represented. So see the muscle and the hip hiking is occurring in the opposite side, the same side, that is during the swing phase of the one leg, the hip hiking is occur and the hip drop in the stance phase leg. Okay, look into this positive sign side. Here the muscle is getting elongated. So to compensate this, that is the muscle is not normal, it is weakened. So here the muscle is tight, so he is able to load in their particular limb. Okay, here he cannot able to load their weight. So due to this, the trunk is also bent to the opposite side, and to load this complete weight in the opposite side, the hip hiking is occurring in the stance base limb. Okay, so this results, is called the Trendelenburg test. It is the main key point is a hip hiking in the unaffected side. So in case of both bilateral hip is getting affected means the trunk swaying from side to side, it produces a gait pattern is called the waddling gait. So here the main muscle is affected is gluteus medius. So the first thing is Trendelenburg gait is a single side affected means the gluteus medius either one side is affected, it is called the Trendelenburg gait. If it is affected both the side, it is results in the waggling gait. So it is mainly leads to a three components. That is the first one, the whole weight should be the whole weight of the trunk should be supported by the particular limb. That is especially the hip should support the complete weight, and the stance hip now takes the weight of the swing leg instead by the ground. That is, while shifting the weight to the other limb, this should be in contact with the ground, sorry, in contact with the limb instead of ground. So before going to contact with the ground, the entire weight should be held by the other swinging leg. So it is not occurring in this particular case, that is a gluteus medius. Okay, so the gluteus medius of the stance leg contract to keep the pelvis from dipping on the unsupported side. The reaction force of this contraction passes through the stance hip joint. It leads to the bending of the trunk to the opposite side as occur. So the causes of this Trendelenburg gait is the painful hip, especially osteoarthritis and the rheumatoid arthritis of the hip joint, the hip abductor weakness, and abnormal hip joint, that is congenital dislocation of the hip, on the coxa vara and slipped femoral epiphysis. In these cases, we can notice this Trendelenburg gait and the wide walking base and the unequal leg length. The next is anterior trunk bending. Here, the patient, that is a person, will walk with the forward at the time of heel contact. That is more propulsion over the forward side during his heel contact. The purpose of this gait pattern is to compensate for inadequacy of the knee extensor. Which one is the knee extensor muscle? Can anyone say?
Quadriceps.
Good. So the quadriceps is getting weakness means the patient results with the anterior trunk bending gait. The next is the posterior trunk bending. Around the heel contact, the subject moves this whole trunk backward in the sagittal plane. It means the purpose of this gait pattern is to compensate for the ineffective hip extensor. Which one is a hip extensor here?
Hamstrings.
Hamstrings.
Good. So the different type of posterior trunk bending may occur early in the swing phase. That is, during the swing phase, the posterior trunk bend is majorly occur, where the subject may throw the trunk backward in order to propel swinging leg forward. So instead of moving his limb forward, he used to go back and then to bring the swinging leg forward. Okay, to compensate for this weakness, especially in the hip flexor or the spasticity of the hip extensors. So the posterior trunk bending may also occur when the hip is ankylosed. So in case of the ankylosing spondylitis also, you can see this posterior trunk bending. The next is increased lumbar lordosis. One second. Santosh sir, sir, it's getting time. Shall I continue? Yes, sir. Thank you. So next is increased lumbar lordosis. It means the most common case of increased lumbar lordosis is a flexion contraction of the hip. This deformity causes the slide length to be very short by preventing the femur from moving backward from its flexed position. We have seen this picture already. That is during the stride length, uh, that is stance phase, our the pelvic rotation should occur. Okay, to prevent that flexion and extension of the hip, the pelvic rotation should occur here. Because of the increased lordosis, the stride length will be very short, and also it may result in the loss of pelvic rotation. So it results in the increased lumbar lordosis. The next is functional leg length discrepancy. It may seen in the congenital also, and also may be due to in any case of traumatic injury. So in this, the leg are not necessarily different lengths when measured on the examination table. You people have looked into it, I think so. True length and apparent length, that is our limb length measurement. So in this, one or both legs are unable to adjust the appropriate length for a particular phase of gait cycle. So the main thing we can see into this is four types of gait because of this leg length discrepancy alone. So it is closely related to this kind of gait abnormalities and designed to overcome the same problem. This gait abnormality frequently results with the neurological problem. So the first thing is circumdactory gait. In this, the ground contact by the swinging leg can be avoided if it is swinging outward. So hope you have seen the stroke patients. Anybody? Anybody have seen the stroke patients? No, it's okay. Usually we can see this circumdactory gait especially in the stroke patients. Okay, that is a hemiplegic patients, which means the patient with the affected side, they cannot able to flex the knee. As of I said early, they cannot able to flex the knee. So instead of that, they used to swing their hip outward. So they used to swing their hip outward. So it results in the circumdactory gait. That is, the hip will get the complete rotation to the outward. So that is, instead of contacting with the ground, that is, instead of a stance phase, the patient will do the swing phase alone, but in the outward side, it results in the circumdactory gait. The next is hip hiking gait. The hip hiking is nothing but the pelvis is lifted on the side of swinging leg by contraction of the spinal muscles and the lateral abdominal wall. So anyone have an idea in which the hip hiking will occur? Hip hiking gait, in which condition it may occur? Anybody?
Arthritis, ma'am.
Arthritis. Good.
Where
Okay.
the hip
Almost
abductors are weak.
good. So as of we saw this early pendulum.
Yes, sir. Osmet College of Physiotherapy. Bangalore, sir. Priti Nagar. Lagere.
Yes. Yes, sir. Thank you. So as of we said, early is in this quadriceps weakness and the hip flexor weakness. Okay, so this hip hiking will be noticed. The next is steppage gait. It consisting of exaggerated knee and hip flexion to lift the foot higher than usual for increased ground clearance, which means it is usually used to compensate for the foot drop. So here they mentioned that is in the foot drop, especially because of the common peroneal nerve injury, this foot muscles, that is dorsiflexor, will get weak. The completely the plantar the foot will go for a plantar flexion, so they cannot able to do a complete dorsiflexion. Instead of that, they will exaggeratedly use the hip and knee flexion to move the foot higher than the usual side. That is, if we have the normal dorsiflexion, then the heel contact is easily occur. But in this steppage, that is why it is mentioned as steppage in the sense it is otherwise called as the stamping gait also. Instead of the heel contact, the patient will support with the toe only. Initially, because of this foot and plantar flexion, the patient used to walk with the toes. They initially they contact with the toes, then the complete foot. Okay, so here that's why it is otherwise called as a stamping gait or the steppage gait or the foot drop gait. So the next is vaulting the ground clearance. For the swinging leg will be increased with the subject goes up on the toes of stand space leg. So here also the same thing. So to clear the ground, so instead of stand face, the patient used to swing the leg more, and also the toes will go more up to complete the ground. So the toes will not contact with the ground. So the patient will think here the toes is up, but initially the toes only will hit first to the ground. The next is abnormal hip rotation. The gait pattern may involve both the stance phase and the sink phase. Here, the problem with the muscle producing a hip rotation, that is, hip rotation muscles will, if the hip rotation muscles is getting affected or the fault in the way of foot makes contact with the ground as a compensatory movement to overcome some other problem as foot inversion or eversion, quadriceps weakness, or with the hip flexor weakness, it may result in the abnormal hip rotation to complete the cycle. The next is excessive knee extension. Anyone noticed with excessive knee extension patient? Anyone?
No, ma'am.
No, it's okay. Okay, so the excessive knee extension will be, we can see in the polio patients especially. So they will have the quadriceps weakness and also to overcome the gait. That is because of the quadriceps weakness, we cannot able to walk smoothly because the stance phase flexion of knee is lost in that patient because of the hyperextension. There will be loss in the flexion of knee. So to compensate that, they will walk with hand on knees. That is They will place their hand on knees to complete the gait smoothly. Here, in which the knee is angulated backwards while the patient walk. So, because of the quadriceps weakness, they will place over the hand over the knee. That is otherwise called as hand to knee gait also. The next is excessive knee flexion. The knee is normally fully extended twice during the gait cycle. So, as we saw earlier, as we have seen earlier, that is knee have to be flexed and extend should occur. That is, if the patient with the excessive knee flexion, there will be a loss in extension also. So because of the loss in extension, the patient will have chance to fall, and also they could not able to continue, that is complete their gait cycle because of the flexion contraction of knee flexor muscles and the spasticity of the knee flexor, functional leg length discrepancy, or the stiffness of the ankle joint may result in this excessive knee flexion. That is, the knee will be in the position of fixed flexion deformity. Okay, there may be a chance of fall also. The next is inadequate dorsiflexion control. So here the dorsiflexion also is most important to complete our gait pattern. That is, it gives rise to two distinct gait abnormalities. The first thing, between the heel contact and the foot flat. So in between this, the dorsiflexor resists the external plantar flexion movement. So if the dorsiflexor not overcome this plantar flexion movement, then there may be a foot slap occurs. That is, as of we have seen in earlier, is that is steppage gait is equal to this only. But here, if the dorsiflexus is not overcome the plantar flexion movement, there may be a foot lowered gently. That means the foot will easily contact with the ground easily. That is, if it is moved towards the ground, then the toe will be touch the ground easily than heel contact. Okay. Here the same, the failure to raise the foot sufficiently during early swing phase may cause toe drag. So it also seen that foot drop patients, if it is bilateral, the subject may avoid toe drag by high steppage gait. This also we have seen earlier, inadequate dorsiflexion control. So if the patient is having the bilateral foot drop, they cannot able to walk. That means they use their toes only to drag. That is, to clear the swing phase, they used to uh, toe drag. Instead, they use a high stepping. That is increased in knee flexion, and the hip flexion will occur to compensate the heel contact. The next is insufficient pushes off. That is, the weight is taken primarily on the heel, and there is no push off phase in this, because while we walk, the complete weight will be loaded on the heel only. Okay, and also imagine our trunk is not going in the forward propulsion, means we cannot complete this stance phase to the swing phase, right? So here the whole foot being lifted off the ground once. The main cause of this pattern is problem with the triceps surae. Anyone know triceps surae, where it is?
And calf muscle. Two legs of gastrocnemius and soleus.
Good, good. May I know your name, please?
K. Ramkumar.
Good, good. Okay, Papa. So the next
Neuro College of Physiotherapy.
is, yes, sir. Sir, is it, sir? What? Yeah. So here, the triceps surae, Achilles tendon, or the intrinsic muscles of the foot. If there may be a weakness in this three, there may be a chance of insufficient push off. That is, the forward propulsion of our trunk may lose in this. So it leads to insufficient push off, and it also leads to the ground clearance, that is initial stance phase will not occur. It may also result from any foot deformity or pain under the foot. The last one is abnormal walking base. So either increase or decrease in the walking base beyond the normal range, as we seen earlier. The increase in the walking base, that is maybe due to deformity of the abducted hip or the valgus knee, and the instability or the fear of falling, it leads to a increased walking base. So if we have increased walking base means we can notice that their COG is not fall directly in the straight line because of the walking base increase. Okay, so and also it results in easy fall to the side. That is, if the patient is fall, if the patient is having more weight on one particular limb, load the weight more weight on one particular limb, there may be easy chance of fall in that particular side. The COG is also fall to that particular side. So the decreased walking base may result from adduction hip or varus knee deformities. So it also, do you have see anyone the decreased walking base, the patients with the decreased walking base? Students, anyone? No, it is okay. So the decreased walking base leads to leads to here the COG will this here the COG will fall towards the affected side. That is, the patient will bend the trunk instead of moving his limb. Okay, so because there is a reduction in the base of support, so to clear that, he or she have to clear the ground with the use of trunk instead of limb. He used the trunk to move forward. So because of the trunk, which side the trunk is getting bent, so that side the COG will get fall. So there may be also increased chance of fall in this type of patients. So in this abnormal gait, the patient used to walk with the aid. That is, so we have already seen that crutches, walker, or the any type of crutches like walking aid. So to compensate this particular weakness, they can walk with that aid. So this to reduce the fall risk, and also the patient will get the confident initially. After that, we have to wean off that walking aid slowly. The patient should have the confident level. Then we can ask the patient to improve their gait pattern. Thank you. So, any doubts?
Good afternoon, all. I thank Miss Dr. Janani for giving us such a clear explanation about the gait patterns and the gait cycle. It was a bit difficult to understand, but you made it easier through presentation and through your explanation. Thank you for your kind effort, ma'am. Thank you.
Thank you, dear.